All right, take it away, Genesis.
Hi everyone. Thank you for being here today. Today we're going to be talking about deep brain stimulation, specifically in Alzheimer's and Parkinson's disease. And with us we have Samir Rocks. Thank you for being here with us. He's a board certified neurology and neurocritical care by the American Board of Psychiatry and Neurology. He did his residency at Larkin in Miami and his fellowship in UT Southwestern in Dallas. He's currently an attending physician in Dallas, and he has been a physician partner who has provided more than 6 publications to the group. So we're super grateful. Thank you for being here.
Thank you guys for having me.
We also have Kimberly Hoggy. She is a deep brain stimulation therapy rep from Medtronic. I met her during my neurosurgery elective in Cleveland Clinic in Florida. So we're grateful to have her here as well.
Thank you for having
Okay, thank you for being here. So we'll be talking today about deep brain stimulation in Alzheimer's and in Parkinson's disease. The review that I was seeing is this one, which is deep brain stimulation beyond the clinic, navigating the future of Parkinson's and Alzheimer's. It is FDA approved for Parkinson, but not yet for Alzheimer's. So it's an interesting topic. Okay, so let's start with some questions. For you guys, what do you think is the deficiency that Alzheimer's patients have in terms of neurons, neurotransmitters? I wanted to ask you guys. Is it dopamine, acetylcholine? What is decreasing in Alzheimer's? Exactly. What about in Parkinson's disease?
Dopamine.
Exactly. So I wanted to know what you guys knew about DBS. For what do you think DBS is used, deep brain stimulation? Obviously Parkinson's, what else?
Tremors.
Okay, yes.
Very
It's
rarely.
also used,
Very
sorry?
very rarely, like chronic stroke.
Okay.
Can you use it
Also,
for depression? I think I heard about using it for depression in my psych rotation.
okay, it's currently used for OCD as well, and also for dystonias, and as Marco said, for essential tremors. So for essential tremor for Parkinson's, it is FDA approved specifically. So let's start with this question. It is a 71-year-old man who comes to the physician because of involuntary shaking, gait abnormalities for the past year. He also reports depressed mood and diminished smell and taste. Examination shows a shuffling gait, resting tremor in the left hand, and rigidity in both arms. The patient most likely has structural changes in which of the following labeled areas of the brain. So a little bit of review of anatomy. This area is um the thalamus. Here we have the substantia nigra. Here we have the lateral ventricle, the internal capsule, the putamen, and over here we have the globus pallidus, interna and externa. What area is affected in Parkinson's disease?
B?
B. You said B?
Yeah.
Yes, this is the substantia nigra. Correct. So the substantia nigra is where the dopaminergic neurons are contained. So that is a part of the basal ganglia and is what is affected in Parkinson's disease. So Parkinson's disease is as we were saying, it is the degeneration of dopaminergic neurons in the substantia nigra. It is caused by this protein aggregates called Lewy bodies. Those are contained with alpha-synuclein protein. And this protein is in the synaptic vesicles and in non-neuronal cells as well, such as hepatocytes, myocytes, lymphocytes, and erythrocytes. The symptoms are composed of motor and non-motor. The motor symptoms are a progressive motor decline, such as the asymmetric resting tremor. So that means that the patient will have only on one side of the body, and it will be during resting. So the patient is not moving, and this tremor is involuntary. There's also cogwheel rigidity that can be tested in the wrist, in the elbow, also bradykinesia, which is the slowness of movement, and dyskinesias, which is like the twitching and jerks that are random and obviously involuntary. The non-motor symptoms include anosmia, which is the lack of smell. We have also depression and cognitive decline. The current treatment, so there is no disease-modifying treatment, so that means that we're not really treating like the cause, but we're treating the symptoms. And we use dopamine agonists. The most common is levodopa, which is taken orally or through injection. The thing with levodopa is that it has adverse effects. These adverse effects include sleep disorders, so you can't give this medication at night, the patient won't sleep well, like insomnia, sleep attacks, and it also causes dyskinesias. So the fact that Parkinson's has dyskinesias as part of the symptoms and you can give a medication that causes dyskinesias, it's controversial. Also, we can use monoamine oxidase inhibitors, which are seleginine, rapsagilin. These prevent the breakdown of levodopa and dopamine because this enzyme is the one that degrades and breaks it down. So we're inhibiting the inhibitor. These do not need like for the doses to be increased like the levodopa and have milder side effects, but they're not as effective in a later stage of Parkinson's disease. So they need to be supplemented by levodopa and other medications, such as others that I want to mention is, for example, pramipexole, which is a drug that was previously used, but it also causes like addiction disorders such as gambling and stuff. So these medications have a lot of adverse effects. That's the conclusion about the treatment in Parkinson's disease. In Alzheimer's disease, the risk factors are old age, genetics, so having APP, PSEN1, PSEN2, and unhealthy lifestyle has proved to be a risk, hypertension, cerebrovascular disease, depression, and also even microwave exposure has been suspected. The pathogenesis of the Alzheimer's is similar to Parkinson's. It's also like this accumulation in aggregates, but in this case, it's amyloid beta plaques, which are composed of tau protein. This causes a loss of cholinergic neurons and synapses. So the symptoms will be progressive cognitive decline with executive dysfunction, accompanied with behavioral and psychiatric symptoms. The current treatment for Alzheimer's is acetylcholinesterase inhibitors, which is an enzyme that degrades acetylcholines, or again, we're inhibiting the inhibitor. It addresses the cognitive dysfunction. It is effective, but it can only slow the rate of cognitive decline, and it's not really addressing this neuronal loss and brain atrophy that will eventually happen. So this is why they're considering this deep brain stimulation as another treatment that could be more effective, maybe. Another medication is the NMDA receptor antagonist, like memantine, which what it does is to prevent the excitotoxicity and cell death, and therefore decrease the neuronal death and the brain atrophy that causes Alzheimer's. So deep brain stimulation. Deep brain stimulation is a neurosurgical procedure. It involves the implantation of electrodes, and we also have an implantable pulse generator that we put in the chest, that they put in the chest, with an extension to the electrodes. This IPG has a battery and circuitry, which creates these electrical signals, and the DBS allows for the delivery of electrical pulses to areas of the brain. Once the electrodes are positioned in the target, the IPG is implanted in the chest, and the leads running under the skin to the brain. The IPG is adjusted externally. I'm going to show you how it looks for you to have an idea. Different frequencies are used to target specific symptoms. There's a high frequency stimulation and there's a low frequency one to attack different symptoms. So this is the IPG. And here in the next image, we can see how are the electrodes connected with the IPG under the skin. This is how they put the settings. This is connected externally by Bluetooth with the IPG, which is connected to the electrodes. So how do we select patients to see if they're a good candidate for this treatment? We have to consider the diagnosis timeframe. So there's two important things about the diagnosis. One is that we want to diagnose within the first 5 years and to do this treatment within those first 5 years. The controversy with this is that if we don't diagnose like any other diseases throughout those 5 years, let's say this patient has another Parkinson plus syndrome, such as Lewy body disease, cortical basal degeneration, maybe we can't see those symptoms in those first 5 years, and maybe DBS wouldn't be as effective. So that's an ongoing debate because we don't know if in those 5 years we're diagnosing right, but we're still treating it with DBS. So that's something important. We do need a multidisciplinary approach, evaluation composed of neurosurgeons, anesthesiologists, movement disorder specialists, neuropsychologists, radiology, psychiatry, physical therapy, nursing, and social work. Another things that compose this selection criteria for Parkinson's disease is the levodopa response. So if a patient has a good levodopa response, that's a good indicator that they will have a good response to DBS. So studies have found that patients that are responsive to levodopa are more likely to respond to DBS. 30% of the improvement is shown by this scale that they use, which is called Unified Parkinson's Disease Rating Scale, and that shows the responsiveness to levodopa. Another criteria is that there are no or few actual non-levodopa motor responsive symptoms. So that's the contrary of not being responsive to levodopa. And we do want to consider that they don't have any cognitive impairments because this wouldn't be attacked by the DBS. The DBS is directed to the motor symptoms, to the tremors, to the dyskinesias, and not the cognitive impairment that can't be solved by the DBS. Another thing is psychiatric diseases. So if the patient has other psychiatric disease, that can be controlled in this case because we're attacking a target that is going to help with the motor symptoms. Other important factors are age. It is suggested for the patient to be less than 70 years old to be able to do this treatment on them. In terms of Alzheimer's disease, it is a little bit different because since it has not been FDA approved, we don't really have a selecting criteria yet. But we do have some scales and exams that can diagnose this disease, such as ADAS, which is Alzheimer's Disease Assessment Scale, as well as the Mini Mental State Exam, which is for dementias, and the Clinical Dementia Rating. This can help us diagnose, but it's not like a specific criteria that we have for DBS.
Another one you can add on is the MoCA, the Montreal Cognitive Assessment.
Okay, true, yes. Here we have how the IPG is here in the chest, and in the brain we have the electrodes. This one is specifically in the area of the subthalamic nucleus and here in the globus pallidus. Here we can see on the MRI and with colors, the subthalamic nucleus and the electrodes in place. In this image, we can see the difference in between Alzheimer's and Parkinson's, and on the right, a healthy brain, and on the left, a brain with the Alzheimer's or Parkinson's disease. Here we can see the lack of dopamine, and here we can see the brain atrophy. This is like a review of what we've talked about. We can see how is it that the beta amyloids are the ones that cause this degeneration and lack of acetylcholine, as well as in Parkinson's disease, the lack of dopamine. Here, in this image on the left side, we can see in Parkinson's disease, the two locations that DBS is usually targeted in, which is the globus pallidus interna and the subthalamic nucleus. On the right side, these are the places that where Alzheimer's is being studied for DBS, which is the fornix, the ventromedial prefrontal cortex, the nucleus basalis of Maynard, and the hypothalamus. So here we can see a selection in conditions where DBS is used in the area of stimulation specifically, so are the ones that I just mentioned, but in this table we can see like other diseases and which are the locations that they use in DBS. So there are many theories of how is it that DBS works, but they are not sure of what is the exact one, so these are some of them. Number one is that they're inhibiting the target neurons through a variety of ways, but they're disrupting glutamate and increasing the amount of GABA and adenosine. So they're increasing the inhibitory neurotransmitters, such as GABA and adenosine. Theory number two is that they're increasing glutamate, which is that you're increasing the neurotransmitter that is more active. And theory three is that they're inhibiting and activating target neurons by affecting the communication between the cell body and the axons. Theory number four is that they're replacing irregularly firing cells with regularly firing cells and producing these jamming signals that lead to the release of neurotrophins and new neurons. The long-term effects that we're looking for is the improvement of motor fluctuations and tremors for up to 5 years. In terms of adverse effects, they can be procedure related, they can be hardware related, they can be because of stimulation disease progression related. But in those adverse effects include intracranial hemorrhage, which is a percentage of incidence from 0 to 10%, stroke from 0 to 2%, infection from 0 to 15%, lead erosion without infection, which is 1 to 2.5% of incidence, lead migration, and lead fracture, and even death. So the location specifically for Parkinson's is also a controversy. Like when you look for papers, you'll see that there's papers that really show that globus pallidus interna is the best location, and other papers show that spinal thalamic nucleus is the best. So the conclusion that they get to is that globus pallidus interna is a little bit better for dyskinesias. So if you have a patient that has a predominancy of dyskinesias, you would try to do the DBS in the globus pallidus interna. But it is at the discretion of the neurosurgeon, because some neurosurgeons prefer to do the spinal thalamic nucleus, because the spinal thalamic nucleus is better to assess. It has a more consistent location. The GPI is different in every person, like the location is more difficult to attain in a surgery. Something new that has been that probably Kimberly can talk to us about is directional leads. These are designed to adapt the volume of stimulation relative to the position within the target by horizontal and vertical current steering directions. And this means that it will be more precise. It will be a less of the work for the neurosurgeons. But in this video that I was seeing, which is a podcast, they were talking about how is it that Kelly Foote, which is a neurosurgeon, says that doing directional leads will lead for doctors to have less abilities in the neurosurgery spectrum, because practically it does a little bit more of the work for them, but it's more precise and better for the patient. So it is another controversy. Okay, so here we can see the pathways. In blue, we can see how is it that the substantia nigra releases this dopamine. In the green one, this is the one that causes movement. The red one would be the one that inhibits movement. And the yellow one is the hyperactive pathway that it is thought to inhibit aberrant movements. Here we can see how in a healthy patient, the green one is the one that causes movement. So you're inhibiting the GPI and you get movement. In terms of the red one, this is the one that activates the GPI and then you won't have movement. If you have a DBS and you have it in the subthalamic nucleus and you have Parkinson's disease, this patient will have decreased dopamine and the subthalamic nucleus would be inhibited, so there will be less movement. So here we can see how is it that the leads are localized. These are in place in the subthalamic nucleus. Here we can see the lead placement and how is it that the location has to be like in the middle of the subthalamic nucleus to be like the exact position. And here we can see it in the globus pallidus interna, which eventually we want to look for that reduction in the tremors and everything after this is located in place. This is the globus pallidus interna. Here as well, we're seeing the similar image as the subthalamic nucleus. The DBS in Alzheimer's disease, it is different. It is not FDA approved, so they're still studying it. These are the locations that they've been using, but the most common one is the fornix. So they do similar to Parkinson's disease, they do it bilaterally. And what they're looking for is a decrease in the brain, in the atrophy, and the symptoms of cognitive decline. So they stimulate specific areas of the brain, such as the fornix, hippocampus, and nucleus basalis of Maynard, but the most common is the fornix. As you can see here, the maximum that has been studied, 210, has been in the fornix. So DBS increases the neuronal activity in the Papez circuit of the brain by activating neurons in the hippocampus, parahippocampal gyrus, and default mode networks such as the precranius, parietal, and temporal lobe. The most common target is the fornix within the hippocampus. This has shown to increase glucose metabolism and utilization of corticothalamic and corticohippocampal networks. It is associated with better clinical outcomes and also mitigates the neuronal loss and leading to a greater hippocampal volume. The stimulation of the nucleus basalis of Maynard and ventral capsule and ventral striatum has also been studied, but as I have mentioned before, it is the fornix, the one that has shown this difference. So to discuss what we have been talking about, there's a debate on the age in between how young or old we should do this surgery on, because we don't know if we should wait a little bit more to see if the patient really only has Parkinsonism and if these are all of the symptoms, or if we do that, we may lead to a progression of the disease. So that's an ongoing debate. Also, the diagnostic time frame, it being the first 5 years, it affects this, and the mechanism of action is still being studied. As we have seen, we mentioned a lot of theories of how it works, and they're different, so we don't really know the exact way. And the controversy between the subthalamic nucleus and the GPI, depending on the tremor or dyskinesias, is something really subjective, depending on the neurosurgeon. So we need more studies that really show which is the better location for the specific symptoms. So here, in this table, we can see how is it that the mechanism of action of the DBS. So for example, it will increase acetylcholine in Alzheimer's disease, and if we do it through the fornix, so it'll increase the hippocampal volume. In Parkinson's disease, the mechanism of action can be either neuronal inhibition, neuronal activation, which I had mentioned about the GABA, adenosine, glutamate, And also, one of the last theories was the one that about the neurotrophin release, increasing the amount of neurons. So for conclusions, both Parkinson's and Alzheimer's are global health burdens characterized by this neurodegeneration and amyloid protein accumulation. Due to the lack of pharmaceutical therapies that are effective on a long term, we can consider the DBS. Research and clinical trials show promise for DBS in Alzheimer's disease, but further research is needed to know its efficacy and establish it. So these are the references, and thank you so much for the opportunity. Thank you for being here. And if you have any questions for us. Mona.
Yes, thank you for this presentation. It was very interesting, as I'm also very interested in Alzheimer's. My question is, why do they not want to have patients who are 70 years and above, as we see Alzheimer's in older patients? Like, what was the reasoning behind not having it on older patients?
So having a procedure like this, like a surgery like this, such an invasive procedure, a brain surgery would not be as effective in an older person. And they really want to address the fact that we're going to do this because this is going to better their lives. And maybe that person is not really that active after 70, so they wouldn't really need it as much. And like that's the reason why they do it, because they really want to look for a younger patient that really needs to like work, for example, or needs to help with the activities of daily life. But after 70, going through that invasive procedure wouldn't be as effective.
Gotcha. Thank you.
Genesis, a question. The 70-year-old cutoff, it was only for Parkinson's, or it was for Alzheimer's, or it was for both?
Only for Parkinson's disease. For
Okay.
Alzheimer's, since it has not been FDA approved yet, they're just considering it and they haven't put a criteria of age yet.
First of all, great presentation, Genesis. Thank you so much.
Thank you.
I had a question about, so it's the PD patient selection criteria. So
Okay.
the first criteria is that if they have a good levodopa response, then they're more likely to respond to DBS. Why do you think that is?
So that shows that if the patient is responsive to levodopa, it means that the symptoms are really caused by this lack of dopamine. So the subthalamic nucleus, for example, is really attacking this pathway. So we're like showing by the levodopa response that this is what is causing the tremor. So that's why they use the levodopa response to be able to like have a criteria and know if they can do this surgery or not.
I have like a follow-up question from Sam's. So if they do respond well to levodopa, why would they want to consider the surgery in that instance? Like, why would they put themselves through an invasive surgery if they're already being treated well with the medication?
So the thing is that levodopa, usually the patients take it 3-4 times a day, even 5 times a day. So it is insane. Like they need the medication too much. They don't have like a normal life. So they would want to have because for example, after they have DBS, it doesn't mean that they won't use levodopa anymore, but they will use a lot less levodopa, and it would be like a more normal life than to be having all those doses on the daily, and the disease will keep progressing. So the levodopa would keep being less effective over time. So we're like trying to stop this progression by using the DBS.
Got it. Thank you.
And to add to that, Dr. Brooks, probably can add more information, but when a patient is in levodopa, they have the on and off effects. So it tends to wear off. It is responsive, but they can start wearing off in 4 hours, 6 hours. And that's why Genesis is saying like you have to take it again and again and again. And with time, it's not responsive anymore as it was in the initial phase.
Yeah, I think it also
Thank you,
depends
Marcos.
on positive and negative symptoms, right, of Parkinson's disease, right? Levodopa and these things work on positive symptoms, right, with movement disorders, right, versus the anhedonia and the other negative symptoms, right? It's less effective. Obviously, I got a lot of questions on this. Have you guys ever seen like DBS like in the clinic and how these patients respond? I don't know if the rep here has any videos or anything, or if you want to pull up a YouTube video, but it's like quite amazing where the
Yes,
patients
it
are
is.
not able to walk at all. They're sitting in a chair, shuffling gait, everything, right? Resting tremor. They're not moving at all. They're frozen. And when DBS is sort of, when they make the settings changes, right? These patients can stand up, they can walk, right? They can move, right? And I understand from a Parkinson's standpoint, right, how DBS and functional movement disorders, right, can be so effective. And that's very appealing, right? It's a big market right now in terms of functional neurosurgery and neurology residencies, right? As you progress, right? There's a lot of movement, emphasis on research behind movement disorders.
Dr. Rocks, I have seen it, and patients when they are adjusting the DBS, sometimes they have to turn off the DBS, and you can see their movements. You can see their face doing the poker face, the mask face, like they cannot move, and they can tell you after you turn on the DBS and do the adjustment. It was like, no, now I feel better. My mood was angrier. I felt this, and they describe you what they feel.
Yeah. It's quite amazing. And if you could go back to that slide of the for Marcos's purposes on the GPI, substantia nigra, all of that, the pathways. Marcos, for your neurology residency or anybody that's interested in going into neuroresidency, that pathway is heavily tested in terms of inhibitory pathways and stimulatory pathways. They're going to test you if I lesion, right, the GPI, right, what would happen, or the subthalamic nucleus, what would happen, right? That's how you're going to be tested on boards for what type of, do you get a positive movement or do you get inhibitory of movement, which is actually stimulatory, right? So they're going to test you in that way on this pathway. You mentioned on the Alzheimer's, interesting. I mean, I wish Nihal was here, but because he's big into research but you mentioned that it improves outcomes on one of your slides. How were the outcomes evaluated or tested, right? Was this based on mini mental status exam scores? Was this based on MRS? How were the outcomes improved in that way?
Since this was a review, they don't really explain further about how the cognitive decline was decreased. And like in terms of when I was preparing this presentation, I was directed towards the Parkinson's one, but I really liked the review because it showed a lot about DBS.
Yeah.
So I mentioned Alzheimer's, but it hasn't really been studied as much as the Parkinson's.
Right. Like I understand the areas of the brain, right? The fornix, the mammillary bodies, and the hippocampus, right? For episodic memory and things like that, right? It has an ideal understanding, right? If you, help the pathway, right? It would inevitably increase your memory, in a certain ideal theoretical way. Obviously, it hasn't really been tested. That's why I think there was one slide that said clinical, outcomes were improved with fornix, and
here.
Exactly. And so that's why I was wondering how that, how was it making it better and how was this tested? And in the same thing for the Parkinson's disease, obviously, how was the outcomes tested, right? How did it improve it, right? Was it that they had inevitably more movement, which we know, right, that to be true, that they're going to have more movement. But, with your Parkinson's, you mentioned, the medications for just PD. But what about memory, like Parkinson's dementia patients, right? And all these other Parkinson's plus syndromes, right, of misdiagnosis. Those things addressed of, can it improve those clinical outcomes and how are those outcomes measured in that way? Because that I still don't know. I mean, other than, you know, it's just DBS improves PD movement, right? But did it help with any of the dimension components, or was it just purely there's improvement in motor control?
Yes, it is associated with dementia and also with for example, patient could have Lewy body dementia as well, which is another Parkinson plus syndrome. So it needs to be studied more and more and more depending on all of those variations.
Right, right.
Sorry, I don't want to cut in, but I was just looking up a quick search just to try to answer your question, Dr. Samir. So this is saying that for cognitive function, they systematically used MoCAs and mental status examination throughout to kind of assess the patients. And then in regards to quality of life, which is a big part of why patients would want to do DBS instead of just keep, like the point that Genesis made about like keep taking medications on and off and all those complications. It was more they used the PDQ-39 questionnaire, and that kind of answered their quality of life, like whether it was improving with DBS or not.
Sure. Were there ever depression scales used in this?
I believe so. I'm just trying to find exactly what it says.
Because depression can also be, right, a pseudo dementia cause, right? But I agree, that's a good way to look at outcomes, right? That answers at least one part of the question is this is what they used for follow-up to evaluate, did it improve or not? What other questions do people have?
I did want to ask to Kimberly about the time frame in which the DBS is changed. So every 5 years, every 10 years, how is it over time?
So it depends on the generator. We have two right now that are in the Percept family. One is a primary channel battery, which does not require any maintenance, and that will last up to 5 years. The other option is a rechargeable battery, which can be charged every 1 to 2 weeks, and that will last 15 years.
Okay. Okay.
And how much does it take to charge, like fully charge?
So if you started at 0, which we would never want anyone to do, to get to 90, it would be in under an hour. So typically our patients are starting at 70 or 80%. And so it's taking them maybe 20 to the most 30 minutes to charge.
Okay. And can they move around while it's charging, or they have to stay like there?
Sure, they can. They can actually be a passenger in a car. It's a sash that lays around their shoulders. There's a charging disc that's wireless.
Okay.
They just press a button. So yes, if they move, there's a good chance that it might change the location and it won't have the best coupling. But if they tuck it into their shirt or something, they could walk around the house.
Okay, perfect. That was my question, if it was wireless or not.
It is wireless. All of the new stuff. So there's been a lot of groundbreaking changes in DBS over the past 4 or 5 years, and even in the past 2 months, actually. So a lot of good changes happening.
Okay, thank you.
Thank you.
Kimberly, I wanted you to mention about the directional leads that they're currently starting to use them. That's an awesome announcement.
Sure. So the difference with the directional leads, and you had touched on this with talking about the targeting and how in some ways it could create a little bit more work for the surgeon. And the reason for that is that there are now markers. So if we look the surgeon under the loops, they'll be able to see these very small arrows, and that will allow them to know where they're placing it. So they put one of the markers anterior, keeping in mind that, of course, when you're advancing a lead into the brain tissue and as they heal and swelling and everything changes, that position could change. So what we recommend is just a quick AP lateral, maybe just before they leave the hospital the next day. And then we can take a look at that and add that into the clinician programmer, and then we'll know the orientation. And so that allows the clinician to be able to target and maybe to steer the stimulation away from things like internal capsule and such that are causing side effects, muscle contractions, and things like that. So what we have is 4 metal electrodes on each wire. the most dorsal and the most ventral are not segmented, but the two middle electrodes are. They're actually segmented into 3 parts each. So you end up with 8 electrodes, basically. Thank you.
That's awesome. Thank you.
I guess I just have a question following that up. So if we have like 8 electrodes present and, are we firing all 8 of those electrodes like every time the patient needs to try to move, or is it like kind of dependent on where they're placed?
So it would be different for each patient, but typically less is more. We're talking about for Parkinson's, a structure size of an almond. So we really have those 2 middle electrodes basically in the meat of that dorsolateral aspect of the STN. So we're basically using those 2 electrodes, and the goal would be to have like a case positive and then maybe a cathode on one of those electrodes. So typically patients have 1, maybe 2 of the electrodes being used.
Thank you. And then so prior to surgery, do they have to do like imaging and measurements in order to get like an appropriate probe size, or is there like a one size fits all type of thing for them?
Yeah, so there's a lot of work beforehand. So the patient goes in usually a week or 2 before, they have an MRI. So we can use either an F-Gator sequence, but what we really need is a good T1 and a T2. And then those images are loaded up into the DBS software on a Stealth Navigator system. There's other software that can be used too, but that's our Medtronic system. And then the surgeon would merge those. He would complete his planning. He picks out an ACPC and a midline. And then the day of the surgery, when the frame is placed, the patient is sent down to CT. And then that image is merged in, and that is what allows the components and the trajectory for the frame. So we have all of our coordinates based off of the T1, T2, and a CT scan with the frame.
Got it. Thank you.
That's super important because this is how they also target tumors and other things, right? With the Stealth technology, with the neurosurgeon, they can see the MRI, the CT, right, and a 3D navigational pattern, so they know what their approach is.
So do you also do follow-up CT scans to see if it has shifted or moved or not?
I would assume so, at least to make sure your placement is correct, to follow up.
Genesis, can you show the electrodes, the slice of the electrodes, so people can see it better? There we go.
This one?
No, the other one, the one that one. There we go. The other one, the one that has the numbers. So, to my understanding, in the iPad, when you are like adjusting this, you select the frequency and the amplitude of each number, right?
Yes, you can. That's actually called OptiStem, what you're talking about. And so we have independent current control now. So you're right, we can not only control each segment, but each ringed electrode as well. They all have a current, so the milliamp, pulse width, and a frequency.
Okay. And you do it based on the patient symptoms, right? If they have improvement, you leave it there, then you move with the other one, and then you kind of play around with it, right?
Well, that's a really nice segue into what BrainSense is. So I'm not sure if anyone's heard of that, but that is the latest technology that Medtronic has. And what it's doing is targeting local field potentials, searching for those beta peaks that we can see in real time in the clinic, targeting that exact beta peak of each patient. So it's individualized to each patient and their brain, and then adding the stimulation in that exact spot to reduce the patient's motor symptoms. So things are changing really with how we used to have to do a monopolar review that would take sometimes 40 minutes to an hour. And now we have something called electrode identifier that can target those beta peaks, and it will tell you which electrode it feels might be the best place, where they have most of that signal happening. So it's really cutting down the time. We can do a full monopolar review now in under 20 minutes. You know, and then some people will just require the regular monopolar review, and that's fine, but it's a good starting point. And basically we're going off of, you know, the most important thing is what we're seeing clinically. So we want to make sure that the patient's obviously having a responsive beta peak, right? If we're stimming and computer's telling us one thing and we see something else in clinic, then this physician would adjust accordingly. So, but that is really helping a lot. And then we can send the patient home with BrainSense activated. And so as they go throughout their daily life and they take their meds and they eat and, you know, their symptoms fluctuate throughout the day, when they come back into the clinic, the doctor can see the fluctuations that have happened on each day. They can look back for months. And then now we can set up what's called adaptive DBS. So the newest thing that was just approved in February was the adaptive DBS, which allows us to target, again, those beta frequencies, but it's providing stimulation as the patient needs it. So when those beta peaks are higher, it'll give a little bit more stimulation based on thresholds. And when they don't need it, like when they're walking or maybe when they're sleeping, less of the stimulation would be provided. So they're having a more even flow and a more personalized flow of their stimulation throughout the day. So
Thank you so much.
thank you.
I appreciate it.
My pleasure.
Does anybody else have any questions?
I have a non-clinical question. Is this covered by the insurance or is this not so much?
Yes, it is. It's
Okay.
actually covered. We are so fortunate to say that I've been doing this for over 13 years. I've never seen a patient have be declined. A lot of the centers will work if there's any issues with copay, but no, it's covered, completely covered.
Awesome.
Yeah.
Thank you.
What are the indications for coverage? Is it just for Parkinson's, resting tremor, movement, or is Alzheimer's also covered?
So I can only speak to Parkinson's, essential tremor, epilepsy, dystonia, OCD. Those are the only things that Medtronic has approval for. But I can tell you that. So just what Genesis was saying as the indications, you do have to have a UK PDRS score of, oh gosh, I believe it's at least 27% responsive to carbidopa levodopa. That's the biggest one for insurance coverage.
Okay, awesome.
All right, everyone, if there's no further questions, that will conclude our journal club. Thank you again, Genesis, for the awesome presentation discussion, and thank you so much to our guests for being here. We appreciate your knowledge and your wisdom and your experience with this stuff to sort of help us to understand it a little bit better. And yeah, is there anything else, Genesis, that you want to add, or are we
No, thank you so much for you guys for the opportunity for presenting, and to Dr. Rux and Kimberly for being here. They were super helpful and with a lot of knowledge for us. Thank you.
Great job. Thank you, guys.
Thank you.
Thank you.
Thank you.
Thank you.